Hello and welcome to another episode of the Melbourne Athlete Development Podcast. Today, I'm lucky and fortunate to have Dr. Kat Mills with me. Kat, thank you for being here today.
Thank you very much for the invite. It's a pleasure to talk with you.
So, to help give some context to the discussion we'll have today, can you introduce who you are, your background and your current role, and areas of research that you've been involved in?
Sure, I'd love to. So I am a physiotherapist by trade, and I trained, I like to say, back in the dark ages when I talk to my students. Um, I'm currently an comprehensive academic at Macquarie University, where I'm a senior lecturer in their Doctor of Physiotherapy program. And within that, I teach across 5 different units, right from some specialist sports physiotherapy into professional healthcare, which talks more about the ethics of being in the health profession. And I teach into some research subjects as well. And I spend my time researching. I'm very diverse in my research, but primarily I'm focused on lower limb pain and particularly joint pain across the lifespan. I'm quite interested in footwear and running, which was my PhD background, and then more so recently into more implementation and trying to get some of these mechanisms and management that we investigate, translating those into clinical practice.
I always appreciate talking to people like whether they're researchers or clinicians with more diverse backgrounds. And I mean, I have my own bias to it, but I feel like being a bit more of a generalist and having exposure to lots of different areas can be very useful for helping solve some of the complexities of, human problems like musculoskeletal problems, if we're talking specifically in musculoskeletal physiotherapy, as opposed to, I think, the very specialized world that we're moving into. Was that a conscious choice that you made, or is it something that just naturally occurred just based on research projects that you're involved in over time?
I think it was probably a little bit of both. So my PhD was slightly unique with respect to, I was a remotely based student. So I did my PhD through the University of Queensland, but I was actually based at the Australian Institute of Sport for that entire period. So I only set foot onto UQ a couple of times, which meant that I became very good at being an independent researcher, so to be able to run a study from start to finish all by myself. And then I was really interested in moving around. So I've moved to 5 different universities over my career. And I take my interests as I go. But as part of that, I also do that because I'm really interested to see what everyone else has going on as well. So similar to you, I value generality. And I value having lots of tools in my toolkit. And I've spent my career trying to build that breadth within a general scope that I'm interested in, which is that lower limb pain and particularly around joint pain.
Have you had the opportunity to work overseas as well with your career?
Yeah, so I did my postdoctoral fellowship at the University of Calgary in Canada. So when I finished my PhD, I did a bit of an analysis of where my weaknesses lie, and my PhD was looking very much at clinical biomechanics and physiological effects of orthoses. And one of the things that I really wasn't too confident with my skills on was looking at the forces that create movement. And at the time, and in many ways still is the case, the University of Calgary was seen as a mecca of biomechanics. Ben O'Neill is based there. The Running Injury Clinic, which is where I did my postdoc, was there. And it was really well set up, particularly after the 1988 Calgary Olympic Games. So I was fortunate enough to be awarded an international fellowship to go over as part of the Alberta Innovates Osteoarthritis team. And I spent 2 years working on a very multidisciplinary team in osteoarthritis. And it was a great experience. And I learned a lot and brought a lot back to Australia as well.
Well, and perhaps you've already answered it, but did you find that when you went there that they definitely had different perspectives about how they went and conducted research or the kind of research questions that they focused on? Because that's something that I've considered a lot myself. We're thinking about here in Australia, we as physiotherapists have a particular way of thinking and a particular narrative, I think, of how we do things, but that does vary from place to place depending on where you grew up in the world, your cultural background, and obviously your tertiary education.
Yeah, I'll just get you to repeat the first part of the question again because I didn't quite catch that.
No, that's okay. I was just asking about any particular differences that you noticed about the kind of research they did, or the kind of research questions that they answered. Did you find that there is differences in what people tend to focus on from a research perspective, in different parts of the world?
Uh, yes, but I think a part of it for me was that shock of going from being that remote student into a lab as well.
Yeah. Okay.
So part of it was learning how to work as part of a team where,
Sure.
and when you work as part of a team, you can have lots of diverse interests.
Mm,
And then there is that added culture. Definitely in Calgary, one of the big things that they focused on was an ideology called sustainable research. And what that means is having research that has an output that then can attract some form of monetary value, which can
mm,
then be used to fund more research. So they were really good at that translation into practice as a way of self-funding their own research, which is not something that I was familiar with in Australia. And I haven't seen replicated to the same extent here. And I think it was probably a University of Calgary thing more so than a Canadian thing, because for the most part, we're very, very similar cultures.
mm,
But I think that that's a really interesting way to approach research in terms of realizing that there's only so much research funding and there's
mm.
lots of questions. And so how can we become independent and not so reliant on grant-based funding?
Okay, well, I was going to actually ask then, because you've done a lot of research in knee osteoarthritis, but is that a particular reason why you've actually gone into that area? Because if we look at the burden of chronic disease like OA, it's increasing, it's affecting more and more of the general population. It's only going to become a bigger issue for our healthcare system to manage. Was that something that was particularly drew you to that area of research?
I think there were a couple of things that drew me to osteoarthritis research. And I think, if we're going to be, self-centered, absolutely, there's more funding available in
Hmm.
osteoarthritis research, but that wasn't necessarily the reason why I went there. I went there because looking across my patient base at that time, and I still practice clinically,
Mm,
I was seeing younger and younger people coming into my practice with what seemed to me like osteoarthritis. It
hmm,
was, I was sitting there going, doesn't look like patellofemoral pain anymore.
mm,
This is looking like you've actually got some form of structural joint changes. And, you'd start off, and I'm sure like most people in their early 20s, like osteoarthritis was an old person's disease. That's not what.
yeah, yeah.
And then you're like, hang on, that person's 40. Oh, hang on, that person's 35. Oh,
Mm,
hang on, that person's in their 20s. And look at their imaging. And that doesn't necessarily mean that imaging equals a clinical disease.
yes.
But I got really interested in why all of these young people were starting to have old knees, in inverted commas. And these were people who were still wanting to be active. So
Mm.
it wasn't your stereotypical overweight person in their 60s. It was young people going, okay, my knee might look like this, but how can I still run that 10Ks
Mm.
in 4 weeks' time? My knee hurts or it's getting really effused. What can I do? Because I want to keep moving. And that's why I got interested in osteoarthritis, was because I love to see active people keep moving. And I think it's becoming a big clinical problem as that age of onset really becomes earlier in the life.
Well, and that's actually an interesting question to consider in yourself of what has changed within, our environment that's led to perhaps an increase, well, obviously an increase overall in OA, but potentially an increase in OA in younger individuals. Is that something that you've looked at or explored, whether it's from a research perspective or just even from a personal interest perspective?
Not from a research perspective, but it's
Mm.
definitely on the horizon. So
Mm.
the studies can be really complex, and they can take a
Yeah.
long time to sort of fester away in your brain as to, well, how would I look at this, or exactly what would be the aim of this program of research, and how would I break that up into doable parts? And for me, I had so much that I felt I needed to explore around the base of osteoarthritis that I almost feel like now I've sort of been in this field for about 10 years. I'm starting to be ready to ask those questions. I think I've got
Okay.
a broad enough understanding of right, what happens when people move, or, how do we get access to people and get them access to good therapies? And what do people think when their knees are making funny noises? And we don't yet understand how that is related to pain. So I think it's a testament that there's so many questions to answer that a program of research can take 15 or 20 years even to start honing and getting to where
Excuse
you
me.
want to go. Bless you.
Well, no. Sorry, just tickling my throat today. I've got some water on standby. I might have to stop a couple of times. Well, actually, with that in mind, then it'd be interesting to talk about some of the research you have done in knee-OA, because I know you've looked at things like gait deviations, you've looked at asymmetries, you've looked at things like knee crepitus and potential what that actually potentially means. Could you actually talk a little bit about that? I think it'd be good to start with maybe looking at some of the research you've done in looking at gait analysis in the OA.
Sure. So we've conducted 2 systematic reviews, particularly around gait deviations. One from a more of a biomechanical, so kinetics perspective. So they're the angles that we have when we move and the forces that create those angles. And then neuromuscular, which is the muscle activity that's driving those movements. And I think what I took away from that as a researcher and as someone who did those fairly early in that journey was just how heterogeneous these populations are. And I look back on those studies and I sort of give myself a little pat on the head and go, oh honey, you were so early. Because really what we looked at it was a very much a disease profile, and even the language that we used in those papers where we were like mild knee osteoarthritis compared with severe osteoarthritis. And you're like, well, that's treating the person as a joint. And we do see some systematic changes based on the disease itself that seem to be unique to the stage of a disease someone's at. So for example, people who have a varus or a bow-legged alignment do tend to walk slower. They tend to hit the ground with their knee in less flexion, and then not take their knee through as much flexion as say a healthy control, or as a person who has knee osteoarthritis but doesn't exhibit that valgus and varus malalignment. But I think reflecting on that, that's possibly not necessarily a direct consequence of the disease, because when we then went and had a look at the asymmetry data, and in that study we were particularly interested in having a look at people who had unilateral disease processes, bilateral disease processes, and then we matched them to healthy controls. And my hypothesis was that we should probably see symmetry in the healthy controls as well as the people who are bilateral, because both knees either have nothing going on or they've both got something going on. So the biggest asymmetries we should be seeing is in the unilateral people, because they've got one knee that has a disease process and the other one that doesn't. And we didn't see that. So what we saw was that in people who have bilateral knee osteoarthritis, when they nominate their more painful knee, and now these are knees that under imaging look exactly the same in terms of disease severity, but we were seeing adaptations or deviations occur in the knee that was more painful. And so that was a bit of a light bulb moment for me, in that, well, gait deviations are potentially not happening because of the structural disease process. They're happening because of the pain.
Yes.
And someone who has pain in one knee and not pain in another, that's a different situation to someone who has pain in both knees, but one knee is worse, and they don't want the other knee to get that bad. So now they're actually trying to change the way they walk in a way that, inverted commas again, like saves their one of their knees. And so what I think we can take away from that body of work is that there is structure, and structural changes will, by default, create some change in walking, because you may have a really osteophytic joint. But the real systematic changes we are seeing appear to be driven more by pain and by the illness state, as opposed to what's actually happening at the joints.
Yes. Yeah, but that makes sense though too, because it shows you just how much behavior is influenced by sensation, feelings. Because
Absolutely.
yeah, I mean, people don't seem to necessarily. I even think about it clinically too. Like, why do most people come to see you? They come to see you because they want to see a reduction in pain, not because I want to walk this particular way. It's not necessarily, which is actually an interesting question in itself, and perhaps something interesting to consider with OA because, well, the reality is managing pain of OA can be actually very challenging.
It can be, but it's doable. Whereas we can't change the progress of the disease. So you cannot make a joint that has decreased joint space, chondral lesions, bone marrow lesions, osteophytes. You're not going to make that joint normal again. But what you can do as a clinician is you can drastically improve a person's pain experience to the point where we did a study where we were looking at one of the osteoarthritis management programs that exists in New South Wales. It's called the Osteoarthritis Chronic Care Program. And these are individuals who present to this service several times throughout a year, and they get a very tailored and multidisciplinary program. And over the course of the year, they can go from reporting 8 to 9 out of 10 pain and being on the joint replacement list to 0 pain and saying I've completely recovered.
Oh, wow.
And so it's a phenomenal change that you can make, and actually getting off the joint replacement list. And as part of that study, what we looked at was what the impact of actually being on that list is in the first place. And it's much, much harder to make someone's or help someone's pain get better if they are on that joint replacement list than if they're not. So for us as clinicians, it's a beautiful message that if we can keep someone off an elective joint replacement list for as long as we can, they're actually going to be pain-free for a lot longer than if they are on that joint replacement list. So, so resigning a joint to being damaged and being needed to be replaced is almost a fait accompli with, okay, well, now that person's going to have a lot more pain.
Yeah, so it really ties into the psychology of, I guess, it all too here, and the implications that has on, I guess, someone's overall physiology and state. Because it's an interesting conversation I find too, because it's like you mentioned to begin with. How much does a scan give us information about someone's clinical presentation? Because the reality is, the correlation between certain radiological findings to someone's presentation may not always be great, particularly with some type of insidious gradual onset of symptoms like OA.
Absolutely.
Yet there is certainly still a big issue within society in general, I think, where once people have given certain labels, and like you mentioned, like particularly they said, oh, your knee is so bad, you're going to have to get joint replacement. They often give up. They often are of the belief that, well, nothing is going to help this. And that in itself creates probably one of the biggest barriers to actually reverse that in itself. And I guess that's suggestive of what you were finding with people who are on the list versus who are not on the list and their potential outcomes from conservative management.
Absolutely. Beautiful summary.
Yeah. With that in mind then too, when you think about, well, actually, before I ask that question, you've also done some research in looking at some of the neuromuscular patterns or maladaptations. Can you describe some of the research that you've done and the findings from that?
Sure. So again, this was driven by a systematic review. And when you look at neuromuscular, studies that are looking at neuromuscular, they tend to look at this in two different ways. Either they do a very complex analysis called a principal component analysis, and that's where they kind of throw all of these variables into one pot, and they then put a mathematical model around it to pull out what are the things that are most contributing to a difference between groups. So they start their analysis under the pretense that there is a difference here now, and the mathematical model finds that difference and it weights different variables differently to come up with a fit for that difference. And then the second one is the one that we're probably a little bit more familiar with, which is, well, here is a variable, and are there differences between these two groups? So they start with the variable and look for the difference, as opposed to starting with the difference and looking for the variables. And that was a really interesting exercise, because what it showed was that even from sort of those mild to moderate stages, people's muscles start working harder, and particularly on that lateral, I call it the lateral pillar of the thigh. So biceps femoris and vastus lateralis will start co-contracting, and then they will start increasing amplitude, and then they will have a longer duration. And initially, the vastus medialis and medial gastrocs will join them, for lack of a better term, so that you'll get this whole leg contracting. And effectively what's happening is that someone's trying to splint their leg. As the disease progresses, so I'm talking here now going from moderate to severe, and that's typically accompanied by a lot more laxity, as and particularly on the medial side, where you've lost a lot more joint space, so you're not able to control that medial pillar as well. It really does move into a lateral splint. So biceps femoris, vastus lateralis, lateral gastroc are all starting to turn on with much more greater co-contraction, and greater duration and amplitude. And rectus femoris will start to kick in there as well. So effectively what's happening is that quadricep weakness is a hallmark feature of osteoarthritis. And even though people with osteoarthritis are weaker, they are working so hard to keep their legs stable and to try and unload their knee joint. And the clinical implications are that strong enough is actually still not good enough. They really need to be super strong. And you need to think about the whole limb. It's not just do inner range quad exercises or squats till the cows come home. You need to be looking after the biceps. You need to be looking after that triceps surae, or those shank muscles, because they're all contributing. They're all crossing the knee joint, and they're all trying to stabilize that knee. So strength, absolutely. Whole limb strength, and realizing that you need, it's not left, you don't need them as strong as the other side, you need them stronger.
Well, and the other thing that stands out to me too, and correct me if I'm wrong, is if you're getting all this co-contraction and rigidity, you lose that spring action of the soft tissue system to be able to absorb forces as well. So is that something also we need to consider of, like developing strength through large ranges? And I also then wonder, like, does plyometrics actually play a role in that too, then, to be getting better at being able to absorb forces more effectively?
Look, potentially, I think that's a great question. Definitely the spring is becoming a lot stiffer. So I think part of it would be, if we go back to the psychology of getting people comfortable with using their limb as a spring and not as a stick. And then absolutely plyometrics and working through that stretch shortening cycle could have a role. Where it would, I think, would have to be really carefully placed, because
for sure.
we are talking about, we're not just talking about loading tendons and using them for energy storage and release. It's a little bit more complex than that, and I'm not entirely sure what that would look like. But I see your point, and I think that it's quite a good one.
There's actually a study that was published last year or this year, maybe a couple of years ago, and it was an observational study, but it was looking at doing a analysis of the iliotibial band in individuals with hip OA versus those who didn't. And you actually saw an increase in collagen type 1 versus type 3, which is much more stiff and rigid. So it actually sort of fits into with some of the findings and implications of from some of your research of looking at this overall stiffness that then allows less ability for the iliotibial band, which very much can act like an aponeurotic spring, to be able to then again absorb forces and alter forces through the hip joint as well.
Absolutely. And that's, you'll also offload to the other side as well. So that's why a common clinical picture is knee osteoarthritis on the left and hip osteoarthritis on the right.
Sure.
And I think it's really, people are trying to find absorption strategies.
when you look at neuromuscular research, so obviously you're talking about EMG analysis here, correct?
Yes.
It's something that I it's something that I sometimes I think I get confused, and it's probably a reflection of my lack of knowledge in EMG analysis. But thinking about what EMG tells us versus, say, force output, because you describe some of the things about certainly co-contraction, which makes sense. But you talk about amplitude with EMG findings.
Yep.
How much can the amplitude of EMG findings be correlated to the magnitude of the force that's created from the muscle itself?
So EMG will speak to how much or how many, what the electricity supply is
Mm,
for the muscle.
yeah.
So you can increase amplitude two different ways. You can increase the requirement for contraction, so the force,
Yes.
or you can have a weak muscle that's trying to recruit more muscle fibers to do the same job.
Yes. Okay.
So it depends on the correlation will depend on the context and on the population.
Yes. Yes.
So you can be working hard and recruiting a lot of muscle, or you can be recruiting a small amount of muscle really hard.
Mm. No, that actually makes sense. I think particularly, like you said, with you got to think about the population specifics, because I think of some research, and this is more from like a performance standpoint, that when you look at someone's ability to improve doing a particular physical task, the EMG activity of a muscle goes down because they actually increase the efficiency of how they move.
Efficiency.
But like
Exactly.
in
Yeah.
this context, it makes sense when you think about the someone who's in pain and probably actually getting weaker. They're trying to actually utilize the muscle more, but then develop other maladaptations in regard to things like coordination and timing.
Absolutely. Yeah. Because they're
Yes.
basically just plugging an electrical cord in and powering everything up.
Well, and that actually brings me back then to a question I was going to ask about. You mentioned about the OA management plan in New South Wales and actually some of the good outcomes you've had from that.
Yep.
What kind of things do we need to be thinking about then from an OA management perspective? Because I think the first thing I think about then is you've mentioned some of the biomechanical changes we see in individuals who have pain from OA. Then I also think about the tissue capacity and things like loss of strength, range of movement, power, whatever it may be. Is there certain things that we need to emphasize more than others? And I often think this is a question I often ask myself both from a rehab or performance perspective. Do we focus more on trying to build up things like strength capacity that can help change the biomechanics, or do we need to think about altering biomechanics that then influences the behavior of the muscle? What are your thoughts on this, and what do people suggest how you approach this?
So one of my research hats that I'm really interested in is clinometrics, and
Okay.
particularly that concept of what is clinically significant and what is clinically meaningful.
Mm,
And I'm going to adopt that approach to answering your question.
sure.
And it comes back to what is important to the patient. So, and then you have to juxtapose that with, does it matter how they achieve that goal?
Mm,
So, with respect to management programs and patient-centeredness, goal setting has to sit at the middle of that. So what does someone want to do? And for example, say someone wants to get back to, let's say, running 5 kilometers a couple of times a week, which is
mhm,
not an uncommon request coming through the door. It's okay, does that person need to run and look pretty, or do they just need to run?
yep. Yep.
And how hard is it going to be, and how long is it going to take if we want to get them running pretty versus
Mm,
like getting them just to run? So I think your question is completely patient dependent, because sometimes you look at how someone runs and goes, right, if you run like this, I'm really not comfortable with how that's going to go through your other joints.
sure.
So we need to do a bit of work to
Mm,
get you strong enough to be able to run. Whereas others you look at and you go, okay, you don't look pretty, but we can get this done. And that's when you would focus more on your cardiovascular capacity and looking at probably to bring in some other aids that you could use. So you might try different types of footwear, or you might try different types of surfaces that all can redistribute or change the magnitude of force being applied to the limb. That's probably where I would sit with that, as opposed to saying
sure.
there's a one size fits all response
Yeah. Yeah.
to getting someone back to their function. And when we talk about management programs, it's all about how do we get this person maximally functional. So sometimes it's really important to target biomechanics. Other times it's actually really just important to control their pain. Other times it could be, right, we need some external devices to help you perform that task. And all of those are valid approaches to managing someone if it means they get back to doing something and, again, keeps their joints from being replaced.
Yeah, okay. The other research paper I came across that you'd been involved in was looking at knee crepitus and its impact on exercise behavior. Can you talk a little bit about that? Because that's obviously something that comes up a lot in, from young individuals to older adults, and it's something that may or may not be associated with pain. But does that give us any information about what someone should or shouldn't be doing, or also to some implications or indications for development of things like OA in the future?
Yeah, so we didn't do the study, but Marenka van Middelkoop has done a great cohort study where she looked at crepitus and development of osteoarthritis, and she found that they are related. So someone who has creaky knees is probably on an osteoarthritis track. Our study was a qualitative study where we were really interested in looking at, well, how does that dictate the type of physical activity someone wants to do or their perception of exercise? And so we set it all up and then got hit by COVID. So it was a difficult study to run because we were talking very much hypothetically with people. People weren't doing their usual physical activity during our data collection period. Overall, these were a group of young people. Most of them had reported creaky knees for at least 10 years. So this is not a fast development process. This is something that people will usually early in their 20s start noticing that when they're doing activities that typically load the patellofemoral joints, so those are, you're running, stair climbing, squats, etc., they start to notice their knees creak. And these individuals were really keen to find the right type of exercise. They just weren't sure what exercise was the right type for them. So we were seeing a complete mixed bag and people were really searching. And we concluded that the right type of exercise is the exercise for them that doesn't make their knees creak. They don't like hearing it. So the physiotherapy or the exercise professional approach would be, you need to find the exercise that they like doing, because otherwise they're not going to do it. And it's not stopping their knees from creaking, it's just that their knees don't creak while they're doing that exercise. And that keeps them engaged with exercise a lot more often. They don't necessarily think, well, our sample didn't think that the creaking was doing any damage. And I think partly because they'd had it for so long. So they didn't credit their knee pain to the crepitus, but most had knee pain other times. And they were actually really happy to push through the crepitus if it meant that their knee pain was going to get better. They didn't like having it. They preferred not to have it. But if it meant that their knee pain would stop, they were happy to push.
Is it realistic to think you can get rid of knee crepitus?
I don't think so. No. I don't think so. I can't give you a really good biological explanation of what crepitus is, but no, I've not seen it. And, it's very long duration. So the evidence around it from our studies indicates that no, you don't get rid of crepitus.
Yeah. Okay. Another study that you were involved in that I thought was actually very valuable with some of the findings was the study in 2019 of looking at the benefits of exercise. This is more of just a review paper. And there were a couple of very interesting findings from that. And one of them actually, for me, is not surprising, but I think it's actually really important to highlight, is the exercise frequency with resistance training. And it highlighted that more than 3 sessions per week wasn't necessarily providing additional benefit. Why is this?
Well, when you have a look at exercise all across multiple systems, so the cardiovascular system, endocrinology system, metabolic system, there's clearly a U-shaped curve. So not enough, not great. Too much, not great. And there's this Goldilocks zone in the middle. So it makes sense in a system that's reliant on mitosis, and mitosis happens during rest. that there is a point where you're not giving your body enough time between sessions to have that mitosis. I think on top of that, you're trying to do something every day of the week for the same muscle group. So this isn't someone who goes to the gym 6 days a week but works different muscle groups on different days.
Yes,
this would be sort of same muscle groups. You probably don't have the capacity to work hard enough to actually build strength. So cutting back those sessions and earning that day off in between is a far better approach, because building strength is really hard. Like you have to work really hard to build strength. And then you have to let that muscle micro damage repair before you try and do it again. So 3 comes out on top. So, going twice is better than once. Going 3 times is better than twice, but 4 times is no better than 3. And I think it's because you just run out of days in the week.
The other thing I took from that, and this is something that is very evident clinically, is the importance of intensity, which is obviously tying with what you're saying.
Yeah.
And it's something that I think a lot of people, particularly in the general population, are apprehensive to do. But the importance of high intensity resistance training, i.e. working close to your maximum, and
Absolutely.
and that's obviously for a relative weight. But it's interesting, if you look at one of the best indications for maximizing hypertrophy, it's the amount of sets that you do close to muscular failure, i.e. to the point you can't do any more. And, as you mentioned, obviously, if you're doing training too much and you've got too much cumulative fatigue, you, 1, cannot train at such a high intensity, and 2, you can't recover effectively to make sure that you're overall getting a net anabolic response and not getting to a point where you're causing too much mechanical stress that causes maladaptations to your system.
Yep.
The other thing that came from that paper too that was very interesting is looking at some of the training behaviors of males versus females. Could you elaborate on some of the findings from that too?
So what we found was that on average, women weren't training hard enough to get a strength response. Now, this paper was done in 2019, so the data was older than that. And so whether or not that's still the case,
Yes.
I think, lovely chance to update. But definitely at that point in time, we looked at it, and the data suggested that if you have a look at a rating of perceived exertion scale, so 0 kind of being I could do this all day, it's not taxing, and 10 being like 1 rep max, and 7 being the intensity that you need to work at to get a benefit. There were very few examples from the research where women were working at that 7 and above, which for us was a really striking finding, not only because it presented an amazing opportunity where we could immediately implement a clinical change, but also highlighting potentially some of the reasons why women, for example, get the osteoarthritis in terms of, well, they live with muscles that just aren't strong enough to cope, or some performance markers of how much better you could become being strong enough.
Have there been considerations, and assuming this is still relevant, of how you actually address that problem? Because it seems to actually vary a bit depending on the generation you're working with. When I think of, say, older generations versus younger generations, but has there actually anyone looked at specific strategies, or do you think this is purely just an educational perspective, or is education enough to actually change someone's exercise behaviors?
It's a very broad question, and there's lots of parts to that.
Sure.
I think didactic flows of information don't tend to change behavior. So you need to involve someone. And there has been, and I'm thinking back now into some of the early 2000s when some of the women's gyms were at like their peak.
Yeah, sure.
And I can't remember the paper off the top of my head, but I can distinctly remember reading it, which was, putting women in a female-only environment, they will push harder because that psychosocial context is completely different.
Yes.
But also I think providing some parameters, like within that same review, we found that the biggest risk of injury in a strength-based setting was that people didn't know how to do the exercise properly.
Yes.
So making sure that people know how to do an exercise is one way of facilitating how to get them to lift heavier. Because if they're not lifting properly or pushing properly or throwing properly, whatever, they'll probably max out a lot faster. Now, there are lots of different ways to perform an exercise, and I'm certainly an advocate that you don't have to do something one way every single time.
Yes.
But the principles underlying the task need to remain consistent. And when you have never been shown, and you might be too self-conscious to ask, because there are lots of stigma around being shown how to do exercises in a gym setting, then you're probably less likely to be able to lift heavy. And also just, I think, that encouragement, go get sweaty, lift heavy. And that's where I think some of our more recent female role models in high performance sport have been amazing, because they're so strong and they're so powerful, and they're doing amazing things.
Mm-hmm. The other area of research you've been involved in is barefoot running.
Yes.
It's actually interesting, because I feel like there was a phase, probably more in the early 2010s, where that became a much more in vogue thing, and you saw a lot more people doing it. But interestingly, it seems like it's almost gone the other way now, where it's all about maximal supportive shoes, and obviously there's been a change and a growth in performance running shoes as well. But talking about barefoot running, there's probably a couple of things of. Let's start more broadly. What value does barefoot running actually potentially provide to people?
So when we're talking barefoot, we can be talking minimalist shoe, which is akin to barefoot, and then we can be talking barefoot.
Yes.
And a study done by Rothschild, and you're right, it was in the 2010s, and I think it speaks fabulously to how long research takes when you start something really, really early and then you publish it in 2022. That people were interested in running barefoot for, one, performance, and two, injury risk reduction. And when we have a look at those two reasons why people does running barefoot decrease injuries? No, it doesn't. Doesn't improve performance. And by performance with runners, we're typically talking speed. So does it make you faster? No, it doesn't. So I think a lot of it was, in all honesty, I think a lot of it was trend.
Right.
And it also makes running a lot more economical if you don't have to put shoes on. The things that barefoot running will do that shod running won't do is it will push you further forward onto your forefoot.
Yes.
So someone who is a rear foot striker will likely change to a midfoot or forefoot striker when they run in barefoot, and that's not the case if they were to run in a minimalist shoe. You actually have to take the shoes off completely. It does increase your cadence, so it will elevate your cadence, not by much, and to be frank, I don't think more than what would happen if you decided to run on a treadmill versus overground. So it's still less than that 10% increase that's supposed to have therapeutic benefits. And it will change your vertical ground reactions. So it will drop that first peak and it will smooth out the peak, so you won't get that initial spike in impact forces. But it will increase that active peak. So you're pushing into the ground harder to come off your foot onto the next one. So there's components there that are potentially performance enhancing, but overall, if we want to talk pure speed, it's not doing it.
Well, I was going to say, what would be indications then for doing barefoot running, do you think? Or how would is there a role to implement it to some level, whether it's a recreational runner or even for someone who's a high performance runner?
I think the role could be variety.
Okay.
So I think it was Richard Newton West did a study where he looked at running in lots of
Richard
different
very well.
types. Yeah, so you can check that one with me. I think it was him.
Sure.
I know I've talked about this study with him. And it's actually people who run in lots of different shoes tend to be report fewer injuries than people who run in one particular shoe all the time.
Yes.
And they've also got different environments where shoes are just not conducive. So, for example, I grew up on the beach and we all grew up barefoot running because no one wanted to have their shoes wet.
Yeah, yeah.
So we all needed to adapt to barefoot running. So I think what it does is it makes running more accessible, and it potentially, as part of a larger running program, may have some role.
Now that makes a lot more sense. And actually, I've actually spoken to Richard about this before, of the value of changing your running environment, i.e. like running on flat versus say trail running, because it will just alter the mechanical forces you're experiencing and therefore potentially be something that mitigates injury risk as well. Excuse me. Yeah, and I think that actually makes a lot of sense too, because it seems that the biggest mistake a lot of people make is going from an all to nothing approach, where they go, you know
Absolutely.
what, I'm just going to go barefoot from now on, and then all of a sudden they've got raging Achilles tendon pain, stress fractures in their foot, and they're falling apart.
Absolutely. And if you look at a transition, we talk about this, and Jill Cook and Ebony Rio talk about this a lot when they're rehabilitating tendons. You can add compression or you can add resistance. You don't do both at the same time.
Yes.
The same thing goes for a transition to shoes. You can, when you go to barefoot, two things are happening. One is you're dropping height. So your heel drop, you're going from, usually somewhere between 4 to 8 millimeters, 4 to 12 millimeters. And nowadays 12 is quite popular. So you're dropping that and you're removing protection from the sole of the foot. You wouldn't do two things at once. So that's where, and in our study, when we transitioned people, we put them in a minimalist shoe, which had a 0 drop. So, and we did that first. So we took our participants to the drop first, and then we took away the protection. And we didn't have a control. So that's one of the big limitations of that study. We really couldn't fully critique our transition protocol. But we made that pragmatic choice based off a lot of other literature that literally went traditional shoe to barefoot and had big dropouts and had lots of injuries. We had relatively few injuries in our study, and about 2/3 of our sample actually made it all the way through that transition period. So I would definitely advocate, if someone wishes to remove their shoes, to have an interim or to have a middle point of that transition process.
Just to confirm, you mentioned before that you only noticed the real change in the foot strike position when you went from wearing a shoe to not wearing a shoe. Is that correct?
Yes. Yeah.
Excuse me. So I'm interested then, because you talk. So if you wear a minimalist shoe, even if there actually isn't a heel lift, you still actually maintain a relatively similar foot strike position than you would if you had a more supported shoe. Correct?
Yes. So Jason Bonacci, about 2013, 2014, looked at this same thing. So he had a traditional shoe and a minimalist shoe and barefoot, and was one of the first to propose that shoes are shoes. So if you've got protection on your feet, you're going to hit with a rear foot strike pattern. And then in the transition study that we did, we took that outdoors. So that study was done in a lab, and our study was done, we got people to run basically over a very typical running surface. And we weren't as equally methodologically rigorous, but just not, we didn't use a 3-dimensional lab setup because we were outdoors and we couldn't. But we found the same thing. We found that shoes are shoes. So if you're going to wear any form of covering on your feet, you will run as though you are in a traditional shoe, in that if you're a rear foot striker, you're going to strike with your rear foot. And for us, the way that we looked at it was quite categorical. You were a rear foot striker or you were not a rear foot striker. So we didn't separate out the midfoot. We didn't have the scientific acuity to do so with the methods that we used to collect those data. So I'm not commenting that you'd move maybe slightly forward. You hit with your heel, or you didn't hit with your heel, and that didn't change. So even if you've been running barefoot, when you run in shoes, you'll hit with the heel.
Yes. A question I always like to ask our guests is, interests you have outside of your professional work? Are there any things that you are interested in exploring at the moment? outside of what you're doing in your research and in your professional work?
So we were just talking before. I have two small children, so a lot of my time is made up of them. Um, but I
Excuse
grew
me.
up a runner. You're right. Tickling your throat's bad.
Mm.
Yeah, I grew up a runner, so I do still prioritize exercise. I love to run and I love to get outdoors and run when I can. And when all of that falls apart, I've actually played the piano for a really long time.
Oh, lovely.
So I really love to sit down and play when I get the chance, and it's sort of a meditative experience.
Did you learn to become a classical pianist, or was it something that you picked up more casually?
Yeah, no, I think my mum had aspirations of me being a concert pianist. So I started classical piano lessons as a 3-year-old, and sort of dipped my toe in and out of all sorts of different genres. But I still find the phrasing and sort of the constraints of classical music to be quite homely and quite comforting.
My brother is a classical pianist, so I certainly have grown up a lot with music. You can see a piano in the background
I
there.
can see a piano in your background,
But not
yes.
that I don't live with my brother anymore, but my girlfriend does play, and certainly when my brother's over, we'll get him to play
Yeah,
because yes, there's something to be said about the pursuit of excellence in something like playing an instrument. Because I often think about
yeah,
that with particularly with manual therapy, actually hands-on stuff, which I
yeah.
mean is a whole topic in itself. But I do think of the time it takes to develop palpatory skills that really influence how you actually do hands-on work. And I actually
Mm,
often think about that of, is it something that we actually really underappreciate how long it does to become excellent at being able to feel stuff with your hands. I mean, you could apply that to any skill, obviously, but I think particularly with hands-on stuff, because I feel like particularly in physiotherapy, there's a lot of discussions about intellectual discussions and thinking a lot about research and understanding concepts, but then the ability to be able to see something or feel something, and
mm,
the art and the time it takes to actually develop that skill. You're probably
absolutely. And I
you're probably a fair way ahead. Actually, you probably developed a lot of those very good sensory skills from all those years of piano playing.
Well, I was about to say, I know when I've been playing a lot, um, my hands are so much stronger,
Mm,
and I can really differentiate if I'm sort of feeling a joy. I'm like, okay, well, no, this finger feels different to this finger. So I would agree.
yes.
I think you start to pay a lot more attention to what the individual hands are saying. And our hands are one of the only surfaces in our body that has glabrous skin, which, has so many receptors,
Yes.
um, that it has amazing potential to be trained. And yeah, I think there's a physical attribute, and then there's that mental acuity of, bigger homunculus representation.
Absolutely, absolutely. Kat, for people who are interested to follow your work, where's the best way to find you on the internet? Are you someone who's active on social media, or
I'm not particularly active on social
no?
media.
That's not a bad thing. In the day and
I'm
age
so,
when everyone's spending all their time online, it's not a bad thing to try and minimize it.
I'm true. I'm probably pretty terrible, actually. No, so the University of Macquarie has research management system called Pure.
Okay.
So if you search me and search Pure, my profile comes up, and all my current projects and fundings and students, if anyone's interested. I'm always interested in getting more people involved. I'm very passionate about building capacity.
Mm.
All of that information can be found there.
Yeah, great. Well, and again, to all of our listeners, please do like, subscribe, leave messages. It really helps us to expand our reach and be able to share conversations like we're having with Kat to more and more people. Kat, thank you very much for being here today.
Thank you very much as well. Thank you.
Take care.